morning. So, or good afternoon, good evening, whenever you may be listening to this. Uh, Today we are talking about renal and urinary disorders. We're going to be looking at the renal and the urinary systems. I did post two videos that you might find helpful dealing with anatomy, dealing with hormonal components. I am not going to be reviewing any of that with this material. That is something that should have been covered in A&P1, A&P2, and I do not want to go back. I want to keep on moving forward. So, if you need a refresher, those videos are available to you. So, the objectives for this course, I am going to combine renal and urinary together. So we will be comparing the abnormal assessment findings commonly seen in clients with urinary disorders to those found on a quote-unquote normal assessment, comparing the abnormal assessment findings commonly seen in clients with renal disorders compared to someone who does not have a renal disorder. We will contrast the pathophysiology, the clinical manifestations, treatments, medical and nursing care for a client with these urinary disorders. And we're going to be talking about urinary tract infections. We're going to talk about UTIs, which are very common. We are going to be talking about urolithiasis. We are talking about bladder cancer. We will contrast the pathophysiology and clinical manifestations, treatments, medical and nursing care for a client with renal disorders. And when we are talking about renal disorders, I am talking about polycystic kidney disease. I am talking about pyelonephritis, acute glomerulonephritis, renal failure, and then renal cancer. We will judge the appropriateness and the safety of the more common treatment used for a client with urinary disorders and judge the same appropriateness and safety of the more common treatment used for a client with renal disorders, meaning medications, dietary, and fluid restrictions. Because again, clients with urinary disorders and clients with renal disorders, a lot of those disorders involve lifestyle changes. Not all of them pleasant, but they are lifestyle changes. And we will be evaluating the needs of the client with urinary disorders and their families as well for education, emotional support, discharge planning. Same thing with renal disorders. We are talking about education, emotional support, and discharge planning. And because we are nurses, we are going to be formulating those care plans for health restoration for a client with a urinary disorder and also for a renal disorder. So here we are looking at the renal and the urinary systems. On the left, you are seeing the anterior view. On the right, you are seeing the posterior view, and here you can see the kidneys. The kidneys are located right below the lungs, and we have just left the respiratory system, so we are working our way down the body. You can see that where the ureters are, you can see where the bladder is, and then where the urethra is. So we are going to be starting with the kidneys and then working our way down to the bladder. Here you are looking at the anatomy of the kidney. And again, I'm not going to spend a lot of time on this because we have already been through A&P1 and A&P2. But in case you just needed a refresher about the anatomy of the kidney, this will serve as that. And we are talking about nephrons. And the nephron is the functional unit of the kidney. The work of filtering the blood to remove waste products and urine production will occur here. It will occur in the nephron. And here we are seeing the anatomy of the nephron. And again, This is serving as a review, so if you just need to place something in your mind, how this works, what is going on, perhaps this will be of help. And so, when we are in the clinical area, we are talking about lab studies. We're always looking at lab studies, and we are connecting those lab studies to what is going on with our patient. And so this is never more true as when we are looking at lab studies and talking about the kidneys and looking at the renal system and looking at the urinary system. This will help us give a very good picture of what is going on with our client, and this will also serve invaluable with doctor in helping create that care plan. And here we are looking at the glomerular filtration rate, the GFR, and this is the amount of blood that is filtered in a set amount of time. A normal GFR is approximately 125 milliliters per minute. Approximately 1 to 3 liters of filtrate, which is electrolytes, water, urea, nitrogen, creatinine, and glucose, is excreted as urine each day. And this we know because when we look at a urinalysis sample, we will see all of these things. And the rate of the GFR is dependent upon several factors, which include systemic blood pressure, blood flow, and then blood volume. So the kidneys will have some ability to change the pressure within the glomerular capillaries because we are always striving for homeostasis. The body is always trying to put itself back in balance. So the kidneys here and the GFR is a powerful compensatory mechanism. However, it cannot compensate for a systolic blood pressure that is below 70. There is nothing we can do once the blood pressure drops that low. So water balance and then electrolyte imbalance. And we know that the kidneys are very powerful in playing a role in electrolytes and balancing the body. So the role of the kidneys in maintaining water balance is invaluable. Invaluable. When the kidneys lose this regulatory capacity, homeostasis is then altered, and then all the body systems will be affected because anything that is going on in the renal system is going to affect pretty much every other system in the body. So complete loss of this regulatory function can result in death because the body can no longer compensate. And if the body cannot compensate, and if we are not aware, and if we cannot intervene, then our client will pass on. So the kidneys control the composition of the blood by reabsorbing and secreting electrolytes to maintain them within normal ranges. So acid-base balance. Now, when we talk about acid-base balance in the past, we have always talked about the respiratory system. And we know somewhere along the way that the kidneys were somehow involved, but I didn't really delve very deeply into it because we were talking about the respiratory system and how all that played into. But now we are going to be talking about acid-base balance and how the kidneys are going to play a part in balancing the body. So to maintain homeostasis, the pH of the blood must constantly remain between 7.35 and 7.45. And we remember this from when we are talking about ABGs and when we are talking about respiratory status, that is the number, 7.35 and 7.45. So a serum pH, and we're talking about the hydrogen levels, less than 7.35 is acidosis, and we know this. And a serum pH greater than 7.45 is alkalosis. And I know that we remember this also. And there are 3 bodily mechanisms that will work to maintain normal serum pH levels. So an acid-base buffer system, regulation by the respiratory system, and then regulation by the renal system is all going to work to maintain this normal pH level that is so, so important. So the role of the kidneys in regulating the acid-base balance is invaluable because cells within the body cannot survive and function properly when the pH is not maintained within the normal range. And we remember this. We remember this from respiratory systems. So in acidosis, the kidney tubules will excrete the hydrogen and they will reabsorb bicarbonate to increase the serum pH to a normal level. And so this is when the kidneys are trying to compensate for something that is going on in the respiratory system, right? If our client is in respiratory acidosis, then here we go. These kidneys are going to kick in. They're going to excrete the hydrogen because we want to bring the body back into balance, and we're going to work to reabsorb bicarbonate so that we can bring the body down from an acidotic level more towards, or bring the body up towards a more normal level. Excuse me. So vitamin D. Vitamin D here with the kidneys is incredibly important because the client with renal impairment can have deficiencies in activated vitamin D and then decrease serum calcium level. Now let's think about what happens when our serum calcium levels are depleted, right? So when I think about calcium, then therefore I have to think about bones. I have to think about fractures because without this serum calcium, the bones are going to become very dry and very brittle, and this is going to put your client at a risk for injury. So in this sense, this would be, if we were talking nursing diagnoses, this would be a primary nursing diagnosis where you have a client that is in that has chronic kidney disease or some kind of kidney issue going on, and they have a deficient calcium level and a deficient vitamin D level, then they are going to be at a greater risk for injury should they fall or should they somehow harm themselves because their bones are going to be very dry, very brittle. And because of the inverse relationship of calcium and phosphate, serum phosphate is typically increased in clients with renal impairment. So, as with everything, the first thing we have to do when we meet up with our client is we have to collect a subjective client history. This is critical when we are assessing any body function, right? We are always going to start with the H&P. It is always at the beginning. When the renal and the urinary systems are evaluated, demographic data will be collected, and this will include their gender, their age, their race, their socioeconomic status. What do they do for a living? What are their dietary habits? What is their nutritional status? And then what are their personal habits? So, because of the variations in the anatomy of the male and female urinary systems, each gender is going to be predisposed to specific complications because males and females are not made the same way, right? This we know. So females are more prone to develop UTIs, urinary tract infections, more often than males because females have a shorter urethra. So the presence of the prostate gland in males will introduce the potential for complications including prostatitis, benign prostatic hypertrophy, that BPH, non-malignant enlargement of the prostate gland. This is when the prostate just becomes enlarged due to the normal aging process, and then prostate cancer. So changes in the urinary system and its function will occur with increasing age, right? And we know this. Aging also increases the risk of developing bladder cancer. Race should also be considered because research has revealed an increased incidence of hypertension and diabetes mellitus in the African American population. So, something to be aware of. Both conditions are precursors in the development of renal dysfunction. Socioeconomic status should also be assessed when evaluating renal function. Research has revealed that relationships among those with low socioeconomic status, low levels of education, and lack of access to health care to the development of chronic conditions that increase the risk of renal complications. And we know this, right? We have seen this many, many times where someone who does not have access to health care, where maybe finance is a barrier to them obtaining health care, transportation is a barrier, um, knowledge deficit is a barrier. They don't realize that they have symptoms when they actually do have symptoms. So when someone does not address something that is very insignificant and benign, I don't want to say insignificant, but benign, such as a urinary tract infection, something that can be fixed very easily with an antibiotic and forcing fluids, but yet it doesn't get treated, and then it turns into a complicated UTI, and then before we know it, we have a full-blown kidney infection, all because your client did not seek treatment early enough. And low socioeconomic status has also been linked to a higher incidence of bladder cancer. So, a thorough review of dietary intake should occur. What is their nutritional status? What are their eating habits? Are they drinking enough water? This, if you were to ask me how much water I drink in a day, you would roll your eyes, because I will drink anything before I will drink a glass of water. I'm going to drink some tea. I'm going to drink a coffee. I love soda, which is so bad for the renal system and the urinary system. But it is a habit. I freely admit it. I do try and work in some water, but it doesn't always work out for me. And so if you were doing my nutritional intake regarding water, you would want to roll your eyes. So consumption of foods that are high in protein, dairy products, and salt may lead to an increased development of renal calculi, those renal stones, those kidney stones. Inadequate volume intake also increases the risk of developing a UTI because we are not flushing the toxins out of the body. Renal calculi, those kidney stones, because we are not flushing those salts and those proteins out of the body, and then renal failure. So a dietary review may reveal changes in appetite and taste sensation that may be present with renal failure, because these are one of the clinical manifestations when we are talking about renal failure, that there is a change in the appetite. There's a change in the appetite because they do lose taste sensation, but also because once those toxins begin to build up in the body, they're feeling a little nauseous, they just don't have an appetite, they may have some vomiting. Smoking. Here we are again, and then again. Smoking history should be assessed because smoking is the primary risk factor for the development of bladder cancer. I can't say this enough, that we are constantly talking to our clients that smoke about smoking cessation. Educating clients regarding the need for smoking cessation and providing them with strategies for cessation are the responsibilities of the nurse. This is going to be part of your patient education. Then we are going to look at personal and family health history, because a lot of these disorders, a lot of these diseases will travel in families. They will be familial. So clients should be questioned about their overall health status. And then alterations in the functioning of the renal and the urinary systems can produce systemic effects. So sometimes, such as nausea, chronic vomiting, flank pain, burning with urination, all of these things come from the renal and the urinary systems, and sometimes your clients will just pass it off. So complaints of fatigue, changes in weight, excessive thirst, and signs of fluid retention are symptoms that warrant further investigation of the functioning of the renal and the urinary systems. So when you're talking to your client says, you know what, at the end of the day, I'm really, really tired. Well, everybody's really tired at the end of the day, and so this is something that they may dismiss. If they're really, really thirsty, they may have said, well, I ate something that was a little salty. Or what do we think about when we think about excessive thirst? We always think diabetes, right? And then fluid retention. At the end of the day, when your client says, you know what, my ankles are always swollen at the end of the day. My shoes feel really tight. My socks are digging into me. Do we dismiss that? Sometimes we do, because at the end of the day, if there's somebody that walks, like a nurse, a waitress, somebody who has a job, working in a grocery store where they're standing up all day, yes, at the end of the day, just because of gravity, they're going to have fluid in the lower extremities. Chronic conditions such as diabetes and hypertension can compromise blood flow to and through the kidneys, resulting in complications. A personal history of neurological defects, urological cancers, frequent UTIs, and then trauma to the urinary tract should also be assessed. So we need to know everything. We want to cover all of our bases. Conditions such as diabetes and hypertension have a hereditary component. This we remember, and it is vital to assess the family history of the client for the presence of these conditions, because we remember that diabetes and hypertension, as well as cardiac disease, will travel in families. So the family history should also be assessed for the presence of kidney disease, urological failure, and then frequent UTIs. The urinary and reproductive systems are closely related, so we need to have a very brief sexual and reproductive history conversation, because sometimes these conditions, these clinical manifestations can overlap. So medications, because the kidneys are filtering, right, we have to talk about medications. So it is essential to collect a thorough history of a client's current and past use of over-the-counter medications, prescription medications, vitamins, and then any herbs or supplements that they may be taking. Many classes of medications are known to affect the normal functioning of the urinary system. So medications such as diuretics will increase the quantity and frequency of urine output. And that's because that's what they're designed to do, right? When you take a diuretic, you know that this is what's going to happen. Your client is they're going to void more, and they're going to void more frequently. Medications including some chemotherapeutic agents, pyridium, and then macrodantin are known to alter the color of urine. They will turn the urine an orange. However, if your client is very, very dehydrated to begin with before they start taking these medications, this pyridium or this macrodantin, then what's going to happen is, because their urine is so concentrated, it will either look a very, very deep, deep orange that in the toilet bowl may resemble a red or a pinkish. And they may actually think that they're bleeding. They may think that they have hematuria. So when your client is taking this medication, it's very important to explain to them that it is going to change the color of their urine. Classes of medications that are used to treat neurological and musculoskeletal disorders can affect the normal functioning of the muscles and the nerves controlling bladder contraction and then relaxation. So this can lead to urinary incontinence, urinary retention, and then other difficulties that are in voiding. So one of the reasons for urinary incontinence, if you're talking to a client, may not be their age. Age is not always a factor when it comes to incontinence. I know that we want to associate the two, but incontinence is not always a normal factor in the aging process. Sometimes it's the medication. Sometimes they might have a UTI and they're having urinary frequency and then urinary urgency, and they just can't make it to the bathroom. Sometimes it's their medication. If they're taking a diuretic and if they're moving a little slower, they're going to have that urgency and that frequency because of the medication, and they can't get to the bathroom. It's not that they don't have the control. They do have the control. It's just a side effect. It's just something else is going on. And so incontinence can always be outside of the normal aging process. So medication may lead to urinary incontinence, urinary retention, and then other difficulties in voiding. Many classes of medications are also known to be toxic to the kidneys, and so we call these medications nephrotoxic. And on page 1353 in your textbook, there is a table, there is a chart, and you can review those medications that may be nephrotoxic to the kidneys. So a client that is prescribed these medications must be closely monitored for complications that will be related to this nephrotoxicity. So, renal and urinary assessment. When assessing the renal and the urinary systems, question the client regarding changes in the appearance, and we're talking about clarity and color, the odor of the urine, the pattern of urination, and the ability to voluntarily control their voiding. So, listen up, and then listen up one more time. A change in the color of the urine may be a result of medications, as we just said, pyridium or macrodantin. They may be overly hydrated. If they're overly hydrated, then their urine is going to be very, very clear. It might be a very light yellow. It might be clear if they're very overly hydrated. Dehydration. If they're dehydrated, then their urine is going to be very, very dark and very, very concentrated. It might be a very, very dark yellow. Or the presence of blood in the urine, and we call that hematuria. Changes in the odor of urine may be caused by medications, hydration status, or the presence of an infectious organism. So remember, somebody who has a UTI, especially a kidney infection, once they go into the bathroom or they use the restroom, I have been with patients where their urinary tract infection is so complicated that I am on the other side of the door, and you can actually smell the urine because it is that foul. It is that foul. So, a client's pattern of urination should be thoroughly assessed for frequency. What is the flow? What is the amount? Are they truly emptying their bladder? Are they voiding enough? And there is a table of urinary system abnormalities that is on page 1354. It is table 61.1, and you might want to take a look at that table. So the mode by which a client voids should also be assessed. Not everybody is going to void in the traditional way, right? They may be incontinent because they might have trauma, so they're incontinent. They might have an indwelling catheter. They might self-cath in order to drain their bladder. They might have a nephrostomy tube, in which case they're not going to void at all. They might be a dialysis client that does not void at all. Some clients will void spontaneously. Some clients may eliminate urine via self-catheterization or an indwelling drainage device. Clients requiring the use of such devices to void are at increased risk of developing UTIs. Please remember this. And this is not new information, right? Once we have now been in the hospital setting, that is a huge issue in facilities, right? If your client has an indwelling catheter, how soon can we get it out? Because they are prone for infection. They're prone for developing that UTI, and they should be closely monitored for signs and symptoms of infection. So listen up, and then listen up one more time. Clients requiring the use of such devices to void are at increased risk of developing a UTI and should be closely monitored for signs and symptoms of infection. Clients should also be questioned regarding their ability to voluntarily control their voiding. Can they? Can they? And then the physical examination. So following the collection of the subjective data, because we've just done the history and the physical, and we've asked all the questions and gathered all the information, a physical examination of the client should occur. Vital signs and weight will provide valuable baseline information and then an overall health status. Because vital signs, what are we looking for? We're looking for hypertension. What's their blood pressure? Because we know that the kidneys play a part in that. And then their weight. Are they a little heavier because they're not excreting those toxins? A client's mental status and then the level of consciousness should be noted because cognitive changes may reflect renal dysfunction. And we also know this. right? If you have a client who is on dialysis, or if you have a client with a renal disease, we know this. We know that once those toxins start building up in the body, they get a little cloudy, they're not thinking clearly, their judgment may be impaired because those toxins are building up within the system. Auscultation of the lungs is also vital to assessing the body's overall fluid status because we want to know, are they in fluid overload? So, alterations in the renal and urinary systems will affect all other body systems. So we will begin with an inspection of the skin, the oral mucosa, the abdomen, and then the extremities. So when we're looking at the skin, we are looking at their skin turgor. What is the texture? Does it appear dry? What color is it? And do they have any bruising on their flank? So, and then we're going to check their mouth. What is their breath? Do they have ammonia on their breath? Do they have any inflammation? Do they have mouth stores? Are their oral mucous membranes dry? We're going to look at their abdomen, the uneven contour, unilateral lower abdominal mass. Do they have striae? And striae is considered stretch marks. We're looking at the extremities because we are looking for edema. Usually not nursing will do this, but doctor will look at the urethral meatus. We're looking for a discharge. We're looking at skin lesions. We're looking at rashes. And then we're looking for obvious tissue trauma. Now, this is not to say that the nurse is not going to assess this body part, because if the client needs to be cleaned, if they need personal care, then of course the nurse is going to be in that area, and she is going to be able to assess this area as well. But traditionally it is doctor that will do this. And then auscultation. So when auscultating, and then this is another doctor role. So when auscultating over the abdominal aorta, we are going to be listening for a bruit. And we know what a bruit is. A bruit is a swishing sound, a whooshing sound. And this will be produced by an increase in the volume of blood that is traveling through a vessel, or in the decrease of the volume of the fluid that is going through the vessel. So the presence of a bruit will indicate altered blood flow to the kidneys, and it will warrant further investigation. So this is when doctor will begin ordering tests, renal function tests. And then doctor will palpate, and then the percussion. If the client reports pain or tenderness, it is suggestive of kidney inflammation or infection. And then the labs, those all important labs. And I know that we're all looking at the labs and we are all trying to figure out what the labs mean in relation to my client's status. So this is never more important than when we are dealing with a client with a renal or a urinary issue, because this again will help doctor to formulate that care plan so that we can get them well. So blood tests are routinely performed to assess kidney function. The most commonly utilized blood tests will include serum creatinine, the BUN, and then the BUN-creatinine ratio. So additional values that will reflect the functioning of the kidneys will include uric acid and then a bicarbonate level, right? And that bicarbonate level, because we want to know if there is an acid-base balance, remember? So electrolyte values, including sodium, potassium, phosphorus, and calcium, are also monitored as a reflection of kidney function. And again, calcium, because that serum calcium level, if that is low, that is going to put my client at an increased risk for injury. So the client should be educated regarding the indication of the blood test. Sometimes there is no specific client preparation for these blood tests. You know, they're just random. They do not need to be fasting. Abnormal results should always be monitored. So doctor may want to do serial lab studies to monitor for a trend. The serum creatinine. Creatinine is the end product of protein and muscle breakdown by the body. Creatinine is filtered by the kidneys and it is excreted in the urine. No commonly occurring medical condition other than renal dysfunction will cause an increase in the serum creatinine. So that means when you are looking at lab studies for your client, if that creatinine level is elevated, they have a renal issue. They have a kidney issue. The most reliable indicator of kidney function is the serum creatinine, and this will specifically reflect the glomerular filtration. The normal range for serum creatinine in adults is 0.5 to 1.2. Males typically have a slightly higher level than females because they have larger muscle mass. Creatinine production will decrease with age, but it will remain stable. So this is why when we have a client that has a number that is outside the normal range, doctor may want to check it, even if he checks it every 3 months, every 6 months. But he is again looking for a trend. So if it remains stable, then he's going to say, okay, this is the normal aging process where the kidneys, they're getting a little tired, they're not going to work as hard. An increase in the serum creatinine level does not occur until approximately 50% of the kidney's function has been lost. And this is so important because now we know when that number starts to rise, they've already lost 50% of their kidney function. So we're only working with 50%. Any increase will indicate impairment in the renal system and will warrant immediate investigation and then intervention. Because if this is something that we can correct, if this is something that we can fix, we want to fix it in the early stages. That only just makes sense, right? An increase should be attributed to acute and or chronic kidney injury or a disease process. There may be a cancer. They may have diabetes, and we know the part that diabetes plays in kidney function. Neuropathy, shock, congestive heart failure. Congestive heart failure, why? Because of that acid-base balance, right? That fluid overload. And then the consumption of a high-protein diet, because a high-protein diet is going to make the kidneys work a lot harder to filter that protein. So a decrease can be attributed to loss of muscle mass, or certain medications, including some classes of antibiotics. So if there is a decrease in the serum creatinine, then what do? We look at the medications first. The BUN, blood urea nitrogen, the BUN. Urea nitrogen is a byproduct of protein metabolism that is going to occur in the liver. And so now we know that the kidneys and the liver, they're best friends, right? They're going to work together. They're going to act as a team, because the liver also filters, right? So kidneys are going to be responsible for filtering from the blood, measure of the renal excretion of urea nitrogen. The normal range in adults is 8 to 21 milligrams, and an increased level can occur not only in renal dysfunction, but also in liver disease, dehydration, infection, consumption of a high-protein diet, GI bleeding, steroid use, and trauma. So there's a lot of things here that can raise this BUN level. Decreased levels can be indicative of severe liver damage, malnutrition, consumption of a low-protein diet, or even fluid excess. So even though your client is telling you, yes, I follow a very good diet. My nutritional status is fine, and my diet is very healthy. Once we start looking at these lab studies, it's like, yeah, no, you're not. I know you're not. So an elevated BUN level is not diagnostic of renal dysfunction, right? Because it depends on so many different things. The hydration status of the client should be considered when interpreting the level, because if your client is dehydrated, then the BUN is going to be elevated. The BUN should also be assessed in a client with an elevated serum creatinine, right? Because we want to know, is there a correlation between the BUN being elevated and then the creatinine being elevated? So if the BUN and the creatinine are both elevated, well, then that's something to look at. Your client may be dehydrated. So once we hydrate your client, if the BUN comes down to a normal range, but the creatinine still stays elevated, then it is not a hydration status problem. It is a kidney problem. And then we're going to look at the BUN creatinine ratio. And this can be utilized to assess if the cause of the elevated BUN is renal or non-renal in nature. The normal ratio of BUN to creatinine is in the range of 10.1 to 20.1. So in cases of hypotension or hypovolemia, if the BUN rises more quickly, then we know that they're dehydrated. When both the BUN and the creatinine levels are increased and the ratio is within the normal range, then renal dysfunction is likely. Right? Now I know that it's not the hydration status of the client, it's the kidney. Bicarbonate. Bicarbonate levels are typically reported as a component of ABGs, right? And we know this when we look at ABGs. So bicarbonate ions, the HCO3, are alkaline and serve as a buffer in the bloodstream to maintain the pH in the normal range of 7.35 to 7.45. And we remember all of this from when we are talking to about the respiratory status. So the kidneys will regulate the concentration of HCO3, the bicarbonate, in the blood by altering the rate of excretion and then the production of the ions based on the serum pH. So an increase in the number of ions increases the serum pH, resulting in metabolic alkalosis. And this makes sense, right? We remember this. A decrease in the amount of bicarbonate will lower the serum pH, resulting in a state of metabolic acidosis. The normal range for bicarbonate in adults is 24 to 28. And increases in levels can occur as a result of severe vomiting, gastric suctioning, excess loss of potassium, or excess administration of bicarbonate. A decrease in levels can occur in renal failure as the kidneys lose their ability to produce the bicarbonate to buffer the blood. These decreased levels can also occur as a result of diabetic ketoacidosis, in severe diarrhea, malnutrition, or if your client is a burn patient. So, electrolytes. The serum concentrations of several electrolytes are regulated in part by the kidneys, and we look at electrolytes a lot. Every time you're in the clinical setting, you're looking at your client's labs, you're looking at the electrolytes. Values can be examined as a reflection of the functioning of the kidneys, and we know this. So sodium is the primary cation in the extracellular fluid. Sodium exhibits water retaining effects, and we know this, right? Because water and sodium, yes, water and sodium are their best friends. They're like two horny teenagers. They want to be together. So if there is a water molecule in the body and it is going to look and look and look and look and look for that sodium molecule because they lust after each other, they love each other. So in adults, the normal range, is 135 to 145. In the late stages of renal failure, a client's sodium balance can be altered as fluids accumulate in the body because of, the kidney's decreasing ability to filter and then excrete properly. So we know this. If your client is having a high sodium diet, then they're going to hold on to more water, they're going to hold on to more fluids, and then this is going to make it harder for the kidneys to do their job and to filter and excrete. So there's going to be fluid overload. The kidneys are responsible for excreting the majority of the body's potassium and then maintaining it in a narrow range of 3.5 to 5. Potassium is typically one of the first electrolyte values to reflect an alteration in kidney function. So this is the first value that we should be looking at if we think if we think our client's kidney function is impaired. So then this tells me that when I'm looking at my lab studies, the first thing I want to look at is I want to look at the serum creatinine, then I want to look at the BUN, then I want to look at the BUN and creatinine ratio. I might want to look at the GFR. And then after I look at all of that, this is now where I want to come. I want to come to this potassium, and I want to see what this potassium level is. So as kidney function will decline, potassium levels typically increase above the normal level. We call this hyperkalemia, because this can lead to cardiac dysrhythmias and therefore requires immediate recognition and then intervention. And we know this, right? Because we've been working on a telemetry floor. We've been on a telemetry floor, and we know that one of the lab studies that we are always cognizant of is the potassium level, because it can cause a cardiac dysrhythmia. Once that potassium level starts to rise, that needs to be addressed. Phosphorus and calcium are inversely related. As one will increase, the other will decrease. So that's something else to look at. The normal range for phosphorus in adults is 2.5 to 4.5. The kidneys are responsible for excreting phosphorus from the body. So as kidney function decreases, the phosphorus level will increase. In declining kidney function, calcium levels will decrease, which is hypocalcemia, as phosphate levels will increase. Okay, so there's that inversion that we need to be aware of. The normal range for calcium in adults is 8.2 to 10.2. Hypocalcemia also occurs as kidney function declines because the kidneys are unable to produce quantities of vitamin D sufficient for calcium to be reabsorbed from the GI tract. And so again, if all of this happens, one of the things that your client is going to develop is osteoporosis, right? And then that is going to put them at a greater risk for injury, because no calcium in the bones are going to become dry, they're going to become brittle, the kidneys aren't working, the bones are going to become dry and brittle. So, urine tests. The very common urinalysis. A urinalysis will provide an overall examination of urine to provide baseline data or to monitor specific characteristics of the urine. The most precise results are obtained by collecting urine from the client's first void of the day. Is this always possible? No, this is not always possible. Your client is admitted, or they come to the emergency room, or they show up at an urgent care, and they're talking, and they might have symptoms of UTI, and doctor says, "Okay, fine, get me a UA, get me a urinalysis." Well, we know it's not the first void of the day, right? But when it is possible, that is the best time to get it, the first void of the day. To obtain accurate results, the sample should be sent to the lab within 1 hour of being collected, unless, of course, you are in a facility where it's going to be done immediately. I'm getting the specimen, I'm sending it to the lab is doing it right now, they're doing it immediately. When I was doing home care, and I would have to go out and a client and obtain a urinalysis specimen from a client, I had a cooler that was in my car. And I would, have it in the cooler, but I had to leave that client's home and then get to either LabCorp or Quest within the hour to drop it off so that the results could be accurate. If not analyzed within an hour, bacteria will multiply and the pH will become increasingly alkaline. The results will not be accurate. Although not ideal, if the sample cannot be sent to the lab within 1 hour, it should be refrigerated until it can be sent, because in doing home care, I have no other way. Results of the urinalysis will include data on multiple characteristics and then the components of urine, and there is a table on page 1358 in your textbook that you may want to take a look at. Culture and sensitivity, and we have also heard this in the clinical setting, right? I want a UA and I want a CNS. I want the UA because I want to look, and I want to see, what they're spilling or whatever. And now I want the culture and sensitivity, because this is going to be useful to identify the number and types of bacteria that are present. So this is going to give doctor very valuable information. Sensitivity testing will involve combining bacteria isolated in the urine with various classes of antibiotic medications to determine which are the most effective at stopping the multiplication of the bacteria, which is going to halt the infection. The culture and sensitivity will provide data that is useful when planning the best course of treatment for a UTI. So, and if you have been in the clinical setting, and if you've looked at that culture and sensitivity result, you will see that there is a list of antibiotics, and then there is usually an S or an R. An S meaning that that particular bacteria is sensitive to that antibiotic, which means that, yes, this is the antibiotic that doctor may use. If there is an R, it means that that bacteria is resistant to that antibiotic, and that antibiotic is not going to work. Careful medication selection is crucial because medication resistance has become an increasingly problem in managing UTIs and many other infections. So we want to try and get it right the first time. Urine to be tested for culture and sensitivity should be collected using a clean catch technique and should be placed in a sterile specimen container. And there is a box on page 1359 that you may want to review. You may want to review that page 1359, box 61.1. This will ensure that the bacteria identified are not present because of contamination of the urine sample. This will tell us that it is a true clean catch specimen and it has not been contaminated with the client's hands or touching the toilet bowl or anything like that, their clothing. It typically takes 48 to 72 hours to isolate a bacteria. Bacteria commonly isolated in culture samples include E. coli, what a surprise, Klebsiella, and then Streptococci. Composite urine collection. Listen up, ladies and gentlemen. Listen up, and then let's listen up just one more time. Composite urine collection will involve collecting all the urine voided for a defined period of time ranging between 2 and 24 hours. And doctor will be specific about that when he writes his order. He wants a 24-hour urine collection. He wants a 4-hour urine collection. He wants a 6-hour urine collection. So in order to do this and do it properly, we will discard the first voided specimen and then we will begin the urine collection for the 24-hour period. Now, if you are the nurse taking care of this client, this involves telling your techs or telling the nurse's aide, because if they're the one that's going to be in and assisting the client to go to the bathroom or to use the restroom, then they need to know that urine, they need to void into a hat, and then after the hat, it's got to go into this it looks like a gallon container or a 2-liter container, and the urine has to go in there, and it is kept on ice. It is kept cool, because what happens is during that 24-hour collection, or whatever doctor orders, but it's usually a 24-hour collection. During that 24-hour collection, if there is one specimen that is discarded, we have to start the entire collection over again the next day after the first voided specimen. And believe me when I tell you, nobody wants to make that phone call. Nobody wants to make the phone call to the doctor to say a specimen was discarded and we have to start again anew tomorrow. Specimens can be used to measure the quantity of specific components of urine, including the electrolytes, the minerals, the creatinine, the protein, and the glucose levels. So creatinine clearance. Creatinine clearance testing of the urine is a type of composite urine collection, and you will see that in the order. It will say 24-hour urine for creatinine clearance. It is a reliable indicator of the GFR. It will measure the amount of creatinine excreted from the body during a defined period of time, 24 hours, 4 hours, 6 hours, whatever doctor determines. Urine is typically collected for 24 hours, but shorter collection periods may be ordered. And then a blood sample for creatinine is required and can be obtained at any point during the collection of this 24-hour period, or whatever time frame doctor has chosen. And so the urine and the blood sample are compared, and then the creatinine clearance is calculated. And this is sometimes used to ensure adequate dosing of medications. We want to make sure that the kidney is filtering the medications at the proper rate that it should be, and it's not holding on, because then that's going to alter the therapeutic level of the medication. The normal range for creatinine clearance in adults is 85 to 135. Values may be slightly lower in females, and this will occur as a result of renal impairment and then muscle wasting. So urine for cytology. We have also heard this. Get me a urine for cytology. Urine collected for cytology is used to identify abnormal cells. Abnormal cells that are in the urine, because if the abnormal cells are in the urine, then they're either being created in the kidney, somewhere along the renal system, somewhere along the urinary system, maybe in the bladder. Abnormal cells are often present in the urine with bladder cancer. Examination of the urine is used as a diagnostic tool and a treatment marker. So once they are undergoing treatment, we are going to do a urine for cytology to see if we are being successful. A urine sample after the first void of the day is collected and sent to the lab again within 1 hour. And then imaging studies. We're leaving lab studies now, and we are moving into imaging studies. Bedside sonography. We've all done this. It is the bedside bladder scan. It will provide a non-invasive means of estimating the volume of urine collected in the bladder. It can be used to assess for post-void residual urine that is remaining in the bladder after a void. Or we have also done this several hours after a catheter has been removed, and the client says, I feel like I have to go, but I'm not exactly sure. So what we're going to do is we're going to check. We're going to do a bladder scan and check and see how much urine is actually in the bladder. Are they really full? X-rays can reveal masses, obstructions, and calculi within the kidneys and then in the urinary tract. Intravenous urography can reveal tumors, a cyst, calculi, or any obstructions within the urinary tract. Renal ultrasound can be utilized to identify masses, cysts, and obstructions within the kidneys. Computed tomography, the CT scan, is capable of detecting slight variances in densities related to kidney size, tumors or masses, renal vessels, or obstruction. And then magnetic resonance imaging, the MRI, is able to reveal contrast between soft tissues of the body. This is useful in examining the tissues of the kidneys to assess for abnormalities. Cystography and urethrophy can be used to assess the bladder for abnormalities, including calculi and masses. Can also be used to assess the bladder and or urethra if trauma is suspected. This may also be used to detect ureteral reflux. This is where the urine is backflowing from the bladder into the ureters and then back up into the kidney. And the arteriography, and this will involve visualizing the renal vasculature to assess for strictures, if there's any bleeding, for vascular hypertension, and then any vascular abnormalities. Renography, and this is a kidney scan, is utilized to assess renal blood flow. Renal biopsy is useful in ruling out malignant processes and diagnosing renal abnormalities. and then the cystoscopy. And this is a surgical procedure that is used to diagnose and to treat bladder problems. It can be used to assess bladder trauma, urethral trauma, urinary tract obstructions. It can also be used to remove any enlarged prostate gland, bladder tumors, or a renal calculi. So, now we are going to talk about renal disorders. Polycystic kidney disease. Polycystic kidney disease is very near and dear to my heart. It does run in my husband's family. And my sister-in-law is actually diagnosed and has been on dialysis for a few years now. And in the coming months, we are hoping she is now eligible for a not only a kidney, but a dual organ transplant. So we are hoping for a kidney liver. So polycystic kidney disease, PKD, is one of the most common genetic disorders of the world. It represents approximately 10 to 15% of chronic renal disorders. It is a progressive kidney disorder causing excessive growth of fluid-filled cysts in the kidneys, leading to complications over time. There is also involvement of the liver, the spleen, and the pancreas. The liver, because the liver and the kidney are best friends, right? They always want to help each other. They're playing on the same team. There is a 50% chance of genetic inheritance. So that means if one of the parents has it, there is a 50% chance that that the children will have it. However, if the parent does not have it, then the child. So meaning it does not skip a generation. So if the parent does not have it, but the grandparent did, there's no way that the grandchild will. Adult PKD may lie dormant for many years and will usually appear between the ages of 30 to 40 years of age. And a prevalence is the same for men and women, and it always involves both kidneys. It's never just right or left. It always involves both kidneys. So, PKD is a genetic disorder that will manifest in the cortex and medulla of both kidneys and appears as large, thin-walled, fluid-filled cysts. And these cysts range in size from millimeters to centimeters. Cysts will develop as a result of repeated cell division within the renal tubule, occurring several times over the life of the client. So this occurs repeatedly over the years. The compression of the cysts on the underlying tissue will reduce the blood flow and the nutrient supply to the renal tissues. So as the as the cysts become larger and larger, and then as those cysts develop other cysts on top of those cysts, then what happens is it essentially crushes the kidney. Listen up, and then ladies and gentlemen, listen up one more time as we talk about clinical manifestations. No, clinical manifestations appear in the early stages. So, if your client is unaware of his family history, and again, this is why obtaining that client history and that family history is so very important, because this is something that does travel in families. And again, in the early stages, unless your client knows that there is a 50% chance that they may have it, if they are unaware of either of their parents having it, then they will not know. However, the symptoms will appear as the cysts become larger. And the first symptom that your client will notice or will be diagnosed with is hypertension. And this hypertension is a result of damage to the surrounding renal structures caused by the enlargement of the cysts. So again, if your client is unaware, they're going to think that they're just having hypertension because their blood pressure is up. Maybe they're also a diabetic. Maybe they're under stress at the time and they think that their blood pressure is just rising because they're buying a house, going through a divorce, they just lost a family member, they're under stress at work. They just might think that anything is going on that will raise their hypertension. They may not connect it to PKD if they are unaware of their history. Then hematuria, which will occur secondly, occurs because of the rupture of the cyst. It has nothing to do with the kidney. Well, it has something to do with the kidney, but really they will see hematuria, they will see blood in the urine because these cysts are popping, and then the blood is going to be excreted in the urine. The client may complain of lower back pain or flank pain, a headache, or pain in the abdominal area. And in the beginning stages, these may be very insidious. They might say, oh, I was out working in the yard and that gave me my back pain. I was helping my daughter move and that gave me my back pain. I, just have a little bit of upset stomach. Feels like I have cramps. I'm not exactly sure. Or a headache, and they may pass a headache off as anything. The client may initially manifest a urinary tract infection, urinary frequency, or urinary calculi that may cause severe pain as a result of obstruction to the urinary flow. Physical examination may reveal bilateral enlarged kidneys or an increased abdominal girth. And this is another thing that your client may notice. They may notice that their belly is getting larger and they're not exactly sure why, or they just might attribute it to a weight gain. Diagnosis. Diagnosis is generally made based on clinical manifestations and then the patient and family history. With PKD, the patient and client family history is very, very important. Lab tests such as the UA will reveal blood, hematuria, and then bacteria in the urine. Definitive diagnosis is determined by an abdominal ultrasound, an MRI, an IVP, or a CAT scan. Diagnostic imaging can reveal other complications such as cysts on the liver and then other abdominal organs, because once these cysts begin to grow and multiply, they are just going to grow and multiply. So a renal ultrasound can visibly show the cysts, where they are, and how large they are. So, ladies and gentlemen, treatment for PKD. Management is very similar to the management of end-stage renal disease because of the renal impairment caused by the cysts. Enlarged cysts obstruct and will compress the surrounding tissue, causing a reduction in renal circulation. And so this also contributes to the death of the kidney because there is no blood flow to the kidney because of the cysts compressing everything. So impairment of renal circulation causes renal failure, resulting in decreased clearance of waste and poor fluid, electrolyte, and then acid-base balance. So the fact of all of this happening is going to decrease the functioning of the kidney, but it is going to have now systemic effects because now we're talking about the clearance of waste, which has to do with their cognition, poor fluid and electrolyte imbalance, which has to do with their overall health status, how they're going to feel. Once your fluids and electrolytes are off, either way, fluid overload or hypovolemia, you tend to feel crappy. And then acid-base balance. Severe PKD will require treatment consistent with that of end-stage renal disease, meaning hemodialysis or peritoneal dialysis. Treatment goals will include managing UTIs, managing the client's pain and their hypertension. Managing UTIs will require regular checkups and immediate treatment as the infection appears because the kidney is already compromised, correct? It's already compromised. So if somebody starts out with a very simple urinary tract infection, we don't want that to travel up the urethra and then somehow make its way to the kidney. So now, besides being compromised, now the kidney has an infection. So antibiotics are necessary to control the spread of the infection from getting to the kidney. Pain can be managed by non-narcotic pain medications such as acetaminophen and opiate narcotic pain medications such as morphine. And the reason that we go for acetaminophen as opposed to aspirin is because of Raynaud's syndrome and the complications of that. Severe pain may need to be treated by a nephrectomy as a palliative measure, which means that the kidney is going to become so enlarged or so compressed. And the kidneys are the cysts on the kidneys are going to become so bothersome and so painful to the client that what doctor will do is he will remove the kidney. Now, by this time, your client is already on dialysis and they may not be voiding it all anyway, so it's not going to matter. So sometimes, yes, doctor will do a nephrectomy just to give the client some relief. Hypertension is managed with medications such as angiotensin converting enzyme inhibitors, those ACE medications, or angiotensin receptor blockers. Lifestyle changes such as a proper diet, getting some exercise, and smoking cessation are all recommended. Again, these are lifestyle changes and changes not everyone will welcome. And this treatment is to manage the symptoms only, which means that if your client has polycystic kidney disease and they say, okay, fine, they get it, even in the early stages, and they're like, oh my gosh, I have to pull back on my protein, I have to pull back on my salt intake, and then that's going to handle the PKD. No, that is not true. That is not true. It is a way to manage it, yes, and it will certainly manage the symptoms, but it is not by any means a treatment plan, and it's by no means a cure, because renal transplant is the only curative measure. That is the only curative measure. We have to get the client a new kidney in order for them to be totally cured of the PKD. So complications. Complications are severe hypertension, renal calculi, recurrent UTIs, hematuria, and then heart valve abnormalities because of the effect on the cardiac system. High risk for developing life-threatening aneurysms in the aorta or cerebral circulation. They may manifest as cysts in the liver and then the GI tract, and then this resembles diverticulitis. Cysts that form in the liver destroy surrounding tissues and then will impair the normal function of the liver in degrading waste products of digestion. So now your client is going to develop some digestive issues, and then also, because of the liver being impaired, they also develop cirrhosis of the liver. Cysts in the intestines can cause diverticulitis, and the most common complication is renal failure, and is characterized by the inability of the kidneys to remove waste products from the circulation, and so your client is then on hemodialysis or peritoneal dialysis. So nursing interventions for these patients. Listen up, and then listen up one more time, ladies and gentlemen. We are looking at vital signs. Increased temperature may be present because of an infection. And again, we do not want these clients to get an infection because their renal system is already impaired. Hypertension is present because of changes in the renal tissue caused by the cysts. Increased heart rate may be present as a result of the infection or any pain that they may be experiencing. Diet modifications consistent with impaired renal function, specifically low potassium, phosphorus, protein, and then sodium. Fluid restriction, fluid overload, and heart failure may occur, so these clients are on a fluid restriction. Administer antihypertensive agents as ordered, administer antibiotics as necessary, and administer pain medication as ordered. Patient education. What are we going to teach these clients? They need to know to immediately report signs and symptoms of an infection, or even signs and symptoms of what they think is an infection. And then doctor will do a UA, he may do a UA CNS, and immediately start them on their antibiotic. Follow prescribed dietary restrictions. And again, this is very, very unpleasant for this population because they have to monitor pretty much every morsel of food that goes into their mouth. Follow prescribed antihypertensive therapies because their blood pressure is going to be high because the kidney is involved or the kidney is non-functional. And then follow prescribed antibiotics for any diagnosed UTIs. So how do I know? How do I know that I've done a good job in caring for this client with PKD? Well, the goal of treatment is always to prevent further complications, right? We want them always to remain status quo. Complying with prescribed medications such as antihypertensive to maintain a normal blood pressure. So between dialysis and their antihypertensive, this can be a little tricky because, they're going to take their medications and they're going to be compliant with their medications. And as we know from working in the clinical area, that when they go to dialysis, their blood pressure is going to go a little lower. So that this can be a little tricky in getting the antihypertensive medications correct. Complying with prescribed antibiotics to treat a UTI. Complying with diets that are restricting sodium, potassium, a fluid restriction, and then phosphorus. Vital signs, keeping them within normal limits, and then making sure that they are free of infection. So, pyelonephritis. Pyelonephritis. This is when that urinary tract infection that starts out as very uncomplicated and very benign and can only be treated with an antibiotic is not treated with an antibiotic, and then it becomes complicated, and then it works its way up. It is one of the most common renal diseases. Young women are most often affected, and this is probably due to them being sexually active. Infants and the elderly are also at an increased risk, reflecting anatomical changes and then their hormonal status. The major risk factor is multiple pre-existing UTIs, treated or untreated. And this we know because if it has happened before, then it's going to happen again. So if you have had a urinary tract before and you didn't treat it well, or you didn't treat it immediately and you developed a kidney infection, well, the next time you develop a UTI and don't treat it or don't treat it well, then you know, because it's already happened once, that you are going to develop pyelonephritis. You're going to develop that kidney infection. So infections may be caused by obstructions such as benign prostatic hypertrophy, and this is in the male, long-term use of an indwelling urinary catheter, pregnancy, and then sexual activity in women. So pathophysiology, how does this happen? Inflammation of the renal parenchyma and urinary collecting system. Everything is going to become inflamed and very angry. The most common cause is a bacterial infection that occurs as a result of contamination of the urinary meatus with a bacteria that is found in the GI tract that will ascend via the ureters to the renal tissue. So what are we saying here? We're saying that the most common way that we are going to develop this UTI is probably hygiene, right? Because it's a bacterial infection. It's an inflammatory process that occurs as a result of bacterial invasion of the renal parenchyma. So again, what starts out as a very benign UTI, something that can be handled at the bladder level, now is going to travel up and meet up with the kidney. So acute pyelonephritis usually begins in the renal medulla, and it will spread to the renal cortex. And E. coli is the most common cause. E. coli is the most common cause. So now we are back to hygiene. Other causative agents will include fungi, protozoas, or a virus. And so here you can see how it's traveling up. It's traveling from the urethra to the bladder. The bacteria is going to travel up the ureters, and it is going to head into the kidney. And here we go. Now we have pyelonephritis. So clinical manifestations. Listen up, and listen up one more time, ladies and gentlemen. Clinical manifestations will include signs of infection, which include fever, chills, nausea, vomiting. Once this insignificant UTI develops into a kidney infection, you are going to feel like hell. Back and or flank pain will be present. Enlarged kidneys will be noted on physical examination. This will also include signs of a UTI, such as frequent and painful urination and then hematuria. If you have ever tried to void with a urinary tract infection that has developed into pyelonephritis, it is truly and incredibly painful. You will feel like you are voiding razor blades. It is painful. Diagnosis. This may be diagnosed by history and physical examination combined with lab results. So what are we going to do? We're going to do that UA. We're going to do that CNS. Laboratory testing will include urinalysis, urine culture, blood cultures, and then a complete blood count, which is the CBC. Urinalysis will show pyuria, bacteria, and then hematuria. The WBC cast may be present in the urine. So a complete WBC count will show an increased WBC count and a shift to the left. A shift to the left. If you are looking in doctor's notes when doctor is writing his progress notes and doctor has looked at the lab studies and he's looked at the CBC and he's looked at the differential, and in there he will note that there is a shift to the left, that means that there is an increase in the neutrophils. And what are neutrophils? Neutrophils are little baby white blood cells that grow up to be WBCs. So if there is an increase to the left, and then which means that there's an increase in the neutrophils, we know now that those neutrophils, because they grow up to be WBCs, there's going to be a rise in the WBC count. So treatment. For a kidney infection, hospitalization is most appropriate. It is most appropriate. This will be especially true for pregnant women because of the concern for premature labor, consistent with treatment. Elderly or severely ill clients with other comorbidities such as diabetes, immunodeficiency, or lung disease are also hospitalized to manage or prevent potential complications, because remember, now there is that risk for electrolyte imbalance. There is also the risk for acid-base balance. Outpatient treatment may be acceptable for clients with mild to moderate illness and those who can be stabilized with an oral antibiotic and then adequate hydration. So if we can trust that the client will go home and they will stay hydrated, meaning that they're going to drink their fluids, and that they will take the antibiotic as doctor orders, then they are fine to go home. If not, they need to go to hospital. Clients with frequent infections may be treated prophylactically on low-dose antibiotics, and sometimes you will see this with patients that have chronic kidney disease, because they are so prone to UTIs that they are always on a low maintenance dose of an antibiotic. Because long-term antibiotic use can lead to antibiotic resistance, this we remember, posing a challenge for finding effective treatment over time. So if your client is already on a low-dose prophylactic antibiotic and then develops a UTI, well, now that puts us at a disadvantage, because now we have to find an antibiotic that will actually work. So medications. Medications typically include antibiotics. Management will vary depending on symptoms. Symptoms can be mild to severe. The treatment for mild symptoms will include outpatient treatment with oral antibiotics, or short stay hospitalization with IV antibiotics, and possible continuation with oral antibiotics upon discharge from the hospital. So this means that if somebody has a comorbidity, they have a chronic kidney disease, they have diabetes, they have hypertension, we may put them in hospital just overnight for a short stay, 1 day, 2 days. We're going to start them on IV antibiotics. We're going to start hydrating them with IV fluids. And then once they are in the recovery phase, then, and we can trust that they're going to go home and do what they're supposed to do, then we will discharge them home with an oral antibiotic and tell them to continue their fluids. Broad spectrum antibiotics with aminoglycosides are typically used because we want to try to encompass everything, all bacteria. Bactrim is the most commonly used because of its effectiveness and because of the cost. It is a low-cost antibiotic, and it is very effective with pyelonephritis. It is contraindicated with clients with a sulfa allergy because it is a sulfur drug. Other antibiotics will include fluoroquinolones such as Cipro. So caution should be used with Bactrim and Cipro. It will be contraindicated in childbearing women due to their effect on bone growth. So if you have a teenager who may be sexually active and developed a UTI and then went on to develop a kidney infection, Bactrim or Cipro would not be a very good choice for them. Urine culture and sensitivity testing are important in selecting antibiotics that will eliminate the pathogen while avoiding the use of stronger antibiotics that will increase the risk of antibiotic resistance. So, supportive interventions. Supportive measures may be necessary, such as fluid replacement. So, this means that if I go home and if I can't be trusted to drink enough water, and I cannot be trusted to drink enough water, then I need to be put into the hospital because I need IV fluids, IV support. Clients are encouraged to drink at least 8 glasses of fluid daily. IV fluids may be necessary during hospitalization if the client requires fluid replacement because we want to flush out the kidneys and the bladder, or if the client is dehydrated due to the nausea and vomiting that will come with the pyelonephritis. NSAIDs or narcotic analgesics can be administered to reduce pain. Listen up, and listen up one more time, ladies and gentlemen. Antipyretic medications can be prescribed to help reduce elevated temperatures that are associated with the infection. Urinary analgesics such as pyridium to relieve the discomforts associated with the lower urinary tract discomfort. Now remember, once the doctor has prescribed pyridium, we're going to have to do some patient education because we know that this is going to turn their urine orange. Cranberry juice may prevent bacteria from sticking to the urinary tract structures. And we know this, right? It's the grandmom used to say this. Some people consider it an old wives' tale that if you have the beginning of a urinary tract infection, to use cranberry juice because that will make the urinary tract infection go away. Well, this is why, because it prevents the bacteria from sticking to the urinary tract structures. However, it does nothing for the infection. If the infection is already present, the cranberry juice is not going to help the infection, but you will feel better, and it won't get any worse. Let's put it that way. So intake of large amounts of vitamin C may also inhibit the growth of bacteria by acidifying the urine. So, complications. Recurrent infections or poorly treated pyelonephritis can lead to scarring. It can lead to chronic kidney disease or permanent damage of the kidney. It may also progress to urosepsis, which is bacteria that will migrate to the bloodstream. Widespread inflammation will alter metabolism and can cause multi-system organ failure. So again, a benign urinary tract infection you can see how if it's not treated, if it's not managed, and it works its way up the kidney, into the kidney, and then becomes pyelonephritis, well, if we're not Johnny on the spot with that, and if we're not doing a very good job managing the pyelonephritis, then it will lead to multi-system failure, and your client may pass away. Changes in mental status, fever, tachycardia, tachypnea, hypotension, oliguria, and then leukopenia are all early signs of a urosepsis. So, surgical management. Emergency surgical management may be indicated for clients who experience fever or positive blood culture results that last longer than 48 hours. These clinical manifestations may be indicative of an abscess, or there might be an obstructing calculi, a kidney stone that is somehow impeding the kidney from working, requiring surgical intervention. So what are we going to do? We are going to administer prescribed antibiotics as ordered, administer pain medication as ordered, and then we are going to provide adequate hydration, either PO or IV, as ordered, because we need to be flushing that kidney. So what are we going to teach our client? What are we going to explain to them? We're going to explain the disease condition to the client and the family, because remember, if it's happened once, it can happen again, but we don't want it to happen again. Educate the client and the family on how to avoid the beginning UTI, right? Because if they can manage the UTI, then it will not advance to pyelonephritis. And there is a box on page 1374 that you may want to investigate. You will educate the client and the family on the importance of rest, because this is how the kidney is going to recover. It needs to rest, and take all prescribed medications as they are ordered. And how do I know? How do I know that I've done a good job in caring for this client with pyelonephritis? A well-managed client does not experience symptoms such as burning or pain with urination. There is no urinary frequency. There is no hesitancy. There is no urgency. They do not have nocturia, and there will be no hematuria. Self-care efforts and compliance with treatment are evident from improvements in the symptoms, and then the reduction in recurrent infections. So, ladies and gentlemen, we are going to talk about acute glomerulonephritis. It is inflammation of the glomeruli of the kidney. It is the third leading cause of renal failure in the United States, so it's pretty common. It is caused by various problems, such as an autoimmune disorder, such as Good-Pasteu's syndrome, and this is an autoimmune disease that will attack the lungs and the kidneys. It is also caused by lupus, vasculitis, or an infection from staph. It can be classified as acute or chronic. Acute glomerulonephritis will develop acutely as a result of a complication of an infection and can be found in clients across the lifespan, but it is most often seen in children and young adults, and this is because of hygiene. Chronic glomerulonephritis can result from some of the same causes as acute and may be genetic in nature. So this means that they are prone. They are just simply prone. It develops more slowly with fewer symptoms and results in irreversible damage. May also result from an unresolved acute case, a case that has not been treated. Because again, remember, some of these disorders, many of these disorders, can be treated in the very early stages if the client has access to healthcare, or if the client has transportation, if the client has knowledge that they need to go and see a healthcare provider. And again, this may not be true if they are hindered by a socioeconomic status. Prognosis of the disease is based on the causative agent and the extent of damage to the glomeruli and to surrounding renal structures and functions. Risk factors are infections such as a recent strep infection, immune diseases such as lupus, vasculitis, hypertension, and diabetes. Inflammation of the glomeruli within the Bowman's capsule of the kidney is triggered by an immunological mechanism. Glomerulus is a key structure in the nephron consisting of a network of capillaries where the first step of filtration and urine formation takes place. So remember, way back in the last hour or so when we were talking about the anatomy of the kidney, and we said that the nephron was where the urine was filtered and then created, right? So if you need to, you can go back and you can just review that slide or review that information. And there is an overall decrease in the glomerular filtration rate, the GFR, and an increase in permeability to larger proteins. So as a result of increased permeability to proteins, protein and blood are going to be seen in the urine when we do that urinalysis. Clients will present with edema, a decreased urine output, and they will be hypertensive. Renal lab studies such as BUN and creatinine are going to be elevated. So again, this is why we've discussed all of those lab studies, the serum creatinine, the BUN, the BUN creatinine clearance ratio. So diagnosis. Diagnosis includes a complete medical history and then physical examination and then lab tests. But it is always going to start with that medical history, right? Urinalysis may reveal the presence of WBCs, RBCs, and protein. Other lab tests will include a CBC and a differential, which would demonstrate increased WBCs, and serum chemistries indicating increased serum BUN and creatinine levels. Decreased albumin levels would also be noted. So, treatment. Treatment is going to be based on the cause of the disease and then the symptom management. It will involve medications and then supportive care. Medications will focus on antibiotic treatment, most specifically penicillin. Diuretics and antihypertensive to treat the hypertension. Edema is treated with sodium and then a fluid restriction. So we're going to pull back, remember, because sodium and water, they love each other, right? So if we pull back on the sodium, then what's going to happen? Then the water has nothing to attach to, right? There's no water molecule. So it will just be excreted, and the edema will be resolving. If the BUN is elevated, reductions in dietary protein may be necessary to reduce metabolic waste buildup. Corticosteroids are not always recommended, but may be indicated to modulate the inflammatory process triggered by an immunological mechanism. Why? Well, let's think about what happens when we take a steroid. When we take a steroid, we tend to hold on to fluid, right? And that's not what we want. We don't want that accumulation of fluid. So doctor will not usually recommend a steroid. Plasmapheresis. Plasmapheresis is the separation of blood components to filter out immune complexes, and this may be considered to reduce the immune-triggered inflammation. So filtered plasma is discarded, and red blood cells and a replacement colloid such as donor plasma is then returned to the client. And rest is the most important means of restoration and symptom relief. Whenever you are talking about kidney issues or kidney disease, rest is always imperative. So complications. If untreated or unresponsive to treatment, acute or chronic kidney disease may develop, and this can progress to renal failure within weeks to months. So again, this is something that needs to be acted on fairly quickly in order to preserve your client's life. Nursing interventions, we are going to assess. We're going to look at vital signs. We're looking at daily weights. Your client is going to be on intake and output. We are going to measure the abdominal girth, or we are going to measure the extremities. And this is important to assess for fluid retention. So we're going to look at the extremities for fluid retention. We can measure the abdomen for fluid retention, and also their weight. We can manage their weight. Skin integrity. Edema can cause skin breakdown. Monitor dietary intake. We are going to limit their protein if their BUN is elevated. Lab analysis. We are going to look at renal studies. We're going to look at the WBC. We're going to look at the UA. Listen up, and then listen up one more time, ladies and gentlemen. What actions? We are going to administer antihypertensive as ordered. We're going to administer corticosteroids as ordered. Now remember, this may not be the first line treatment. Doctor may not want to go here, but depending on their inflammation, he may have to, even for short term. Maintain low to moderate protein diet, and then a dietary sodium and fluid restriction. So teaching patient education, we are going to talk to them about the overview of the disease process, and this is something that we will do all the time. We are going to talk about prescribed medications, dietary restrictions, and we are going to educate them on how to avoid future infections. Evaluating care outcomes. How do I know? How do I know that I've done a good job caring for this client? Care outcomes will be based on improvement in kidney function and their symptoms. Their symptoms will be resolved. We are going to monitor the serum BUN. We're going to look at the creatinine. We're going to look at electrolytes, and this is all very important in assessing the condition of the client. So if these lab studies are improving, then I've done a good job. Patient education can be evaluated based on the verbalization of the information regarding the condition, and this is what? This is teach back. So I'm going to educate the client, and then I'm going to have the client teach me. What do you know about this? Do you know how to stay well? Do you know why we do these lab studies? Do you know what the results mean? And then a well-managed client has a blood pressure within normal limits, no edema, and their renal function has returned to normal limits. Renal cancer. Renal cancer. Renal cancer or kidney cancer is one of the most common cancers in the United States. Renal cell carcinoma, adenocarcinoma, is the most common type of renal cancer, and it will occur more often in males 50 to 7 years than in females. And here we go. The use of cigarettes, pipes, and cigars will pose a higher risk. Chewing tobacco and other forms of smokeless tobacco are a major source of cancer-causing nitrosamines that can increase the client's risk. So again, no smoking. A familial association has been linked to first-degree relatives and the incidence of renal cancer. So again, this goes back to obtaining that patient history and then that family history, because again, a lot of these disorders, a lot of these disease processes will travel in families. Other risk factors are obesity, hypertension, exposure to asbestos and gasoline. So that would be occupational, right? Work-related. Pathophysiology. It is usually found in the cortex or pelvis of the kidney. Malignant tumors are the more frequent than the benign tumors. Kidney tumors will compress underlying tissues, reducing circulation to the renal structures and then damaging underlying tissues, much like the cyst will do in PKD. So this compression can lead to compressed renal functioning or renal failure. And then 30% of malignant tumors have mets by the time of diagnosis, which means, again, just like the beginning stages of PKD, there will be no symptoms in the beginning. Location of the mets will include the long bones, the lungs, and the liver. Extension of the cancer into the renal vein and venal cava is common. Clinical manifestations. What are we going to see? What is your client going to say? Well, most clients will be asymptomatic initially in the course of the disease. Eventual stretching, compression, and invading of tumors within the renal structure will cause the classic triad: flank mass, flank pain, and then hematuria. So once the mass has begun on the flank, which will be on the kidney, they are going to develop flank pain, and then they will develop hematuria. So once your client has these three symptoms, they may have cancer. Other symptoms will include abdominal pain, weight loss, hypertension, fever, and anemia. If there is compression of the testicular vein due to the mass, your male client will develop a varicocele, and this is an enlargement of the venous plexus in the scrotum. Several studies are required for this diagnosis. The IVP is the diagnostic test that will detect most masses. Ultrasound is widely used to differentiate between a solid mass, a tumor, and a cyst. Other diagnostic tests will include angiography, percutaneous needle aspiration, a CT, and an MRI. Radionucleotide isotope scanning is used to detect METs. Urine cytology will show the presence of neoplastic or atypical cells. Renal biopsy is utilized to look for cancerous or atypical cells. And then Robson's system of staging is utilized, and that is noted on page 1377 in your textbook, and you may want to look at that table. So, medications. Biological immunotherapy or cytokines can be used to boost the immune system and then target cancer cells for destruction. This therapy can shrink cancer into a small number of clients. So, does it work? Does it not work? Well, we don't know. But it's worth a try, in my opinion. Renal cancer cells are resistant to chemotherapy, so this is not the standard medical treatment. The treatment of renal carcinoma usually involves surgery because remember we can't do chemo, right? So we're going to do surgery. The most common treatment for renal cancer is radical nephrectomy for clients with type 1 and type 2 staging, and then selective type 3 tumors. Radical nephrectomy will remove the involved kidney, the adrenal gland, the surrounding tissues such as the fascia, part of the ureter, and then the draining of the lymph nodes. With early detection, renal cancer has shown a 60 to 70% 5-year survival rate after undergoing radical nephrectomy. In an early or small stage cancer, a partial nephrectomy or nephron-sparing surgery is considered. And this is where an attempt is made to just remove the tumor because remember, we want to preserve that nephron, right? Because that nephron is very important to urine production. So when METS involves the lungs and the long bones or the tumor is inoperable, then radiation therapy is used as a palliative measure. And again, palliative care is only for comfort, and it is only to manage the disease. I know I'm not going to cure anybody. Metastatic renal cancer has a survival rate of 3 to 10% at 5 years. So complications. Complications will involve the disease process as well as the treatment. Compression and stretching of the tissues will cause pain and reduce the circulation needed by the tissues. And the renal system is highly sensitive to reductions in circulating oxygenated blood and the nutrients. Remember, because that's its job. That's the job of the kidney, right? To filter. If untreated, reduced circulation can cause end-stage renal failure, so the kidney is going to die. And if the tumor is not identified in the early stages, which in the early stages is difficult to do because there's no symptoms, right? If the tumor is not identified in the early stages and treatment initiated, then the overall prognosis of the condition is reduced, and then the survival rate is poor. So nursing interventions, what are we going to do? Well, we are nurses, so we are going to assess, then we're going to go back and reassess, and if we have to, we're going to assess a third time. We're going to look at vital signs. Tachycardia may be an indicator of pain, so we're going to be looking. What is their pain? Do they have pain? And then if they are going for surgery, we are going to do a preoperative assessment. We are going to assess their knowledge. We want to make sure that they have all the information that they need to make an informed decision regarding their care. And we are going to do a full systems assessment. We are not going to just do a focused assessment here, because remember, we're talking about the renal system, and the renal system is going to have an effect on every system of the body. So you would want to do a full systems assessment. And then Postoperatively, we are going to do a post-op assessment. Now remember, the things you are going to do here, you are going to do just simple post-op care. This is just going to be any post-op care that you would do for any client that had just had surgery. So we're going to monitor vital signs. Hypotension, tachycardia may reflect dehydration after surgery, and then the need for fluid replacement, right? That can happen with any client. Increased temperature may indicate a surgical site infection. This may not happen for 72 hours. Decreasing SpO2 may indicate a post-op atelectasis. So what do we need to do? Coughing and deep breathing exercises. Monitor intake and output, the color, the consistency. Urine may be pink initially, and this would be expected, right? But bright red blood in the urine will indicate bleeding somewhere, and then doctor is going to have to be notified. Cloudy urine may indicate an infection. We are going to look at the incision site. We may have to do wound care. We are going to check the patency of tubes, drains, catheters. Red or warm incisions with purulent drainage will indicate an infection. Doctor will need to be notified. Limited drainage through drains may indicate an obstruction. So again, doctor needs to be notified. We are going to administer pain medications as ordered. Administer IV hydration as ordered. Encourage PO hydration if they can drink fluids. Adequate hydration post-op is necessary to maintain that circulating volume in the body and give the kidney something to do. It's going to give the kidney something to filter. And we're going to encourage those respiratory exercises, right? Coughing and deep breathing, the use of incentive spirometry, changing position, ambulating is everything that we would do for any post-op client, because we want to prevent those respiratory complications. And then the appropriate care of catheters, the stents, the nephrostomy tubes or drains. Make sure that they're patent. Make sure that they're draining. Wound care as ordered. We're going to look at the wound for the presence of redness, swelling, edema. What does the drainage look like? And is there any drainage present? Because that may indicate infection. But this is not just something that we would do for a renal patient. This is post-op care that we would give any post-op client. Teaching, patient education. What are we going to talk about? We are going to educate the client and the family about the condition and any procedures or diagnostic tests, right? Because they want them to feel comfortable. We want them to know what's coming. We want them to be able to make knowledgeable decisions. And providing education can help to alleviate stress and then therefore improve their recovery. Educate the client and the family about their medications always, always, always. Education regarding prescribed medications will facilitate compliance with the medication regimen. Remember, if a client understands why they're taking their medication and what that medication is going to do for them, then they are more apt to take the medication because they know what the medication is going to do and how it's going to help to resolve the issue. Provide adequate, appropriate resources for counseling regarding disease process, the tests and procedures, changes in body image, and then if there are any financial concerns, because remember, this is going to be a very long recovery. So appropriate resources and counseling will help alleviate stress and grief, because grief can affect the outcome of care procedures. How do I know? How do I know that I've done a good job taking care of this client? Well, a well-managed client will understand the disease and then their treatment options. They will be able to make an informed decision. The client and the family members should be able to report changes in the condition and then anything that is adverse throughout the illness and then after any procedures. If they understand what's going to happen during the procedure and the complications after the procedure, then they are more apt to report them. And then a well-managed post-op client has good pain control, a nice clean incision, an adequate elimination-free from blood or any signs of infection. So, urinary disorders, urinary tract infections. Urinary tract infections account for 8 million doctor visits and more than 100,000 hospital admissions a year. They occur more frequently in females than in males. More than 50% of females will have at least one UTI in their lifetime. The most common age group is women 18 to 30 years of age, and this is thought to be due to cystitis and pregnancy. So, listen up, listen up, listen up, ladies and gentlemen, and then listen up one more time. Sexual activity, diabetes, poor hygiene, estrogen deficiency, recent catheterizations, incomplete bladder emptying, and foreign objects such as kidney or bladder stones will increase the risk for developing a UTI. Listen up. Conditions causing incomplete bladder emptying, such as pelvic organ prolapse, increase risk because of retained urine acting as a reservoir for bacteria. And this is much the same as when we were talking about the lower respiratory diseases, because those fluids were just staying stagnant in the bottom of the lung, right? And that was a reservoir for bacteria. So same thing with the bladder. If the infection is isolated in the lower urinary tract or bladder, it is referred to as a cystitis. If the infection involves the upper urinary tract or the kidneys, it is referred to as a pyelonephritis. And we have already spoken about pyelonephritis. So indwelling catheters will pose a risk for infection. Listen up, listen up, listen up one more time. Indwelling urinary catheters will pose a risk for infection. And we know this because when we are in the clinical area and your patient has a urinary catheter, that is the question. How soon can we get this catheter out? So the pathophysiology. UTIs will occur when bacteria will enter the sterile bladder, causing inflammation. The most common way for bacteria to gain entrance to the bladder is through the urethra. And if we remember our little picture, our little diagram from a few slides back, if you need, you can go back and review that. Females are at risk because of their short urethra and its close proximity to the vagina and to the rectum. So vaginal and fecal flora will migrate to the urethra, causing this urinary tract infection. As men age, their risk for UTIs will increase because of prostate enlargement. So diagnosis is done with a urinalysis and then a urine culture. We are going to do that urinalysis and then that urine and sensitivity. Visual inspection of the specimen will reveal bloody and or cloudy urine. Urinalysis will demonstrate leukocytes, nitrites, hemoglobin, and then bacteria. Leukocytes, or WBCs, and red blood cells are present because of the inflammatory and infectious process. So, E. coli, Enterobacter, Pseudomonas, Klebsiella are all common offenders. E. coli is a common intestinal bacterium, is responsible for approximately 80% of all uncomplicated UTIs. So, treatment. Medications. Treatment is primarily medications. First-line treatment is an antimicrobial therapy. The choice of antibiotic is dependent on the urine culture sensitivity. So again, once we do that clean catch, and we have to be very, very careful about how we obtain that clean catch specimen. And then we're going to take it to the lab. We're going to have it there within 1 hour so that the results will be accurate. And then the lab technician is going to do the culture and sensitivity. They're going to expose it to all of these different antibiotics so we can see what is going to kill the bacteria. So the urine culture tests various antibiotics of the offending bacteria, and then will determine which antibiotic is most appropriate. So an uncomplicated UTI, women who are not pregnant, they are not diabetic, they are not afebrile, or I'm sorry, they are afebrile, can be treated with a 3-day course of antibiotics because it's an uncomplicated UTI. We are catching it right at the beginning stages, right when, the client is telling us that they have symptoms. So the woman is not pregnant, she's not a diabetic, but she does have a fever. She might be feeling, a little, geez, I'm not feeling great. And we can give her a 3-day course of antibiotics and all will be well. Bactrim DS and then Cipro are common antibiotics that will be prescribed because of their efficacy, because they are very efficient. Now, a complicated UTI where the woman is diabetic, she has a fever, or if we have a male, then they are usually treated for 7 to 10 days worth of antibiotics. So uncomplicated, 3 days, complicated, 7 to 10 days. So listen up, and then listen up one more time, ladies and gentlemen. In addition to the antibiotics, bladder analgesics such as pyridium may be used to treat dysuria, frequency, and urgency. Urinalysis and a urine culture are obtained after completing the antibiotics to verify that the infection has been treated appropriately. So, we're going to do a urinalysis and a urine culture and sensitivity, and we're going to identify the antibiotic that needs to be used. In addition to the antibiotic, doctor may order pyridium, right? And so pyridium is one of those medications where we have to tell the client it is going to discolor your urine, so do not be alarmed. And then after your client has done their course of antibiotics for an uncomplicated UTI, it will be a 3-day course. For a complicated UTI, they will take the antibiotic for 7 to 10 days. And then after they have completed the course, then we are going to do another UA and then another culture and sensitivity to make sure that the infection has resolved. So, complications will include drug resistance, or they will develop pyelonephritis, a renal abscess, or urosepsis. Drug resistance is possible when the client does not complete the antibiotics as prescribed. This is when, if it's a 7-day course, and they may take it for 3 days, 4 days, and then they feel better, their symptoms subside, and they're like, oh, well, I guess I'm better now, and I don't need to finish the course, and they don't. So this will make it difficult to find an appropriate antibiotic if and when the infection returns, because now they've complicated the problem by becoming antibiotic resistant. So untreated or incomplete treatment potentially allows for bacteria to migrate to the kidneys, causing pyelonephritis, a renal abscess, or urosepsis, because they did not complete the course. So when you are doing your patient education, please remember that you need to stress to them to complete the course of the antibiotic. Surgical management. Surgical management is reserved for clients with known risk factors such as infections, either bladder or kidney stones, or anatomical defects allowing for incomplete bladder emptying, such as pelvic organ prolapse in women or an enlarged prostate in men. So an example of pelvic organ prolapse is a cystocele, which occurs when the walls between the bladder and the vagina are weakened, allowing the bladder to descend into the vagina. And so, of course, there can be complete emptying. So, and here you can see bladder prolapse and the cystocele developing. So, this change in anatomy prevents the bladder from emptying completely and then acting as that reservoir and growing the bacteria, leading to a UTI. So a surgical intervention will correct the defect in the vaginal wall, allowing the bladder to empty effectively and thereby decreasing the risk for a UTI. Men with an enlarged prostate can also retain urine and develop UTIs. So surgical interventions such as a transurethral resection of the prostate, otherwise known as a TURP, So if you've been in the clinical setting and if you've been taking care of clients and you've heard this, or maybe when you're looking at their past history and physical and it says that they've had a TURP, this is what it is. It will remove excessive prostatic tissue, allowing for complete bladder emptying. And this is what the enlarged prostate looks like in a male. So nursing management, we will assess, because this is what nurses do, and we will assess the client for the following: fever, dysuria, urinary frequency, urinary urgency, gross hematuria, cloudy urine, malodorous urine. Listen up, and then listen up one more time, ladies and gentlemen. We are going to assess vital signs. Elevated temperature, elevated heart rate, and decreased blood pressure may indicate upper urinary tract involvement and then dehydration. Abdominal examination. Suprapubic tenderness can indicate a lower tract infection, and then that costovertebral angle. Costovertebral is posterior. It is at the bottom of the rib cage at the 12th rib. Now the costovertebral angle is a 90-degree angle that is formed between the rib and the spine. And tenderness in this area can indicate an upper tract infection. Urinalysis will be looking for the presence of hematuria, leukocytes, and cloudy urine, because this will indicate infection. And then urine culture. Antibiotic use is dictated by the urine culture sensitivities. What will the bacteria be sensitive to? Actions. We are going to administer antibiotics as ordered, dependent on the urine culture sensitivity. So whatever the bacteria is sensitive to, that is what doctor is going to order, and that's what we're going to administer. Administer bladder analgesics such as pyridium. This will decrease the irritative voiding symptoms such as dysuria, frequency, and urgency. They will report elevated temperature, flat pain, nausea, and vomiting. Increased fluid intake, increased fluids to prevent dehydration and to flush urine and bacteria. Signs and symptoms of a UTI. Early treatment will decrease morbidity. It will decrease the risk for renal failure and urosepsis. Patient education. Ladies and gentlemen, listen up, and then listen up one more time. UTI prevention. Our clients, especially females, need to wipe front to back, and they need to know to urinate before and after intercourse to prevent migration of bacteria to the bladder. I have no idea. I don't know when this happens, because from young children, we teach our young girls to wipe front to back. I have no idea when this happens, where a female gets up and she says, you know what, today is the day. Today is the day. I am no longer going to wipe front to back, but now I'm going to wipe back to front. And then they end up with recurrent UTIs. Medication education. Complete all antibiotics as prescribed. Untreated or incomplete treatment may cause renal failure, urosepsis, or drug resistance. And we will educate the client that pyridium will turn the urine an orange-red color, so as not to be alarmed when they void. How do I know? How do I know that I've done a good job with this client? Well, clients will have resolution of irritative lower urinary tract symptoms after completing their antimicrobial therapy. The health of the kidneys is protected by early and completed treatment. And further risk for UTIs is decreased by increasing fluid intake and wiping front to back after urination and voiding before and after intercourse. So, urolithiasis. Calcifications in the urinary system, commonly referred to as kidney stones. They can occur in the kidneys, in the ureter, in the bladder. Urolithiasis refers to a calculus in the ureter, and it will occur more frequently in males. Family history will increase the risk as well as increase sodium intake. So again, that history and physical and that family history is all important. A client that develops a stone is at an increased risk to develop another stone within 10 years. So if it happened once, it can happen again. How does this happen? Well, it occurs when microscopic crystals in the urinary tract aggregate together, causing a calculus, which is a stone, to occur. 80% of these are calcium. Dehydration will contribute to stone formation due to the concentrated urine. So again, making sure that your client is drinking enough fluids throughout the day will prevent this urolithiasis. Stone causes an obstruction in the uretero-pelvic junction as the urine exits the kidney. And so here you can see where the kidney stone is in the ureter. Do you see where the kidney stone is? So the kidney stone is there. Now please remember, the kidney is working just fine. There's nothing wrong with the kidney. The problem occurs when the kidney produces the urine, and then the urine is coming down the ureter, and it can't pass through because of the kidney. Because of the stone. So clinical manifestations. Major clinical manifestation will be severe pain when the stone lodges in the ureter, causing distension and obstruction of the urine flow. Pain is usually colicky. It will start and it will stop abruptly, and there will be nausea and vomiting. Now, colicky pain, yes, true. However, please know that because the reason that it is colicky pain and it starts and stops is because the only time your client will have pain is when that stone is moving. If the stone is stationary, your client is not going to have any pain. Or it's not, well, that's not exactly true. It's not going to have pain until that urine starts to backflow up into the kidney because it's got nowhere to go. And then they're going to develop that flank pain. So the location of the stone will influence the location of the pain. Upper ureteral stone will cause pain to the referred flank. Lower ureteral stones will cause lower abdominal pain and then genital pain. And gross hematuria is going to be present. And the reason that hematuria is present is because these stones are not smooth. Some of these stones are actually quite jagged. And so when the stone is moving, your client is going to have pain because it's so jagged and your client will experience the hematuria because the stone is going to be cutting the ureter, and that's why it's going to bleed, because the stone is jagged. Diagnostic modality of choice is a non-contrast CT scan. Ultrasound will be recommended in children and pregnant females because of the lack of radiation exposure. So what are we going to do? Well, 50% of stones less than 5 millimeters will just pass spontaneously. The opportunity to pass the stone on their own, which we call a trial of passage, is the first line of treatment. So essentially doing nothing and trying to let the stone pass is what we are going to try first. Narcotics and/or non-steroidal anti-inflammatories, along with antiemetic care, are utilized during the trial of passage, right? Because they're going to feel like crap while they're trying to pass this stone. So Flomax, Cardora, Hytrin can be used to relax musculature of the lower ureter to help the stone pass. If the stone does not pass after 4 to 6 weeks, now I have to tell you, I have never seen a physician allow a trial of passage for this long, 4 to 6 weeks. That is really an extended period of time. Actually, I've never seen a physician go longer than a week, truthfully. But this is the information that was in your textbook. So if a stone does not pass after 4 to 6 weeks, or if this client develops renal colic, which is pain related to the stone, that is unresponsive to narcotics, which means that this is just too painful. They just can't take it anymore. There's nausea, there's vomiting, so now they're dehydrated. There's going to be an electrolyte imbalance, signs of a UTI, then surgical management is required. So surgical management is required when a stone is greater than 10 millimeters, causing severe obstruction and pain, uncontrolled by narcotics, or there is a fever and then the urine is infected. So ureteroscopy, percutaneous nephrolithotomy, and then extracorporeal shockwave lithotripsy are common surgical procedures. So what doctor is going to try and do, because this is a very large stone, so what doctor is going to try and do is he's going to use lithotripsy. He's going to use sound waves to try and zap that stone so that the stone will break apart and essentially be gravel so that the client can pass it. Untreated stones can lead to pyelonephritis, urosepsis, and then irreversible renal damage. A rise in renal function, indicators such as BUN-creatinine, indicates that aggressive treatment of the kidney stone is required. So that's what I mean. A trial of passage for 4 to 6 weeks is really a very long time. And then in that time frame, doctor is going to be doing lab studies, and we're going to be looking at the renal function. So indicators such as the BUN and creatinine going up, saying that, if we don't do something now, this kidney is in danger. We need to do something now. We need to treat it now. So nursing intervention, we are going to assess, go back and reassess, and then assess again. We are looking at vital signs. We are monitoring pain, severe intermittent pain associated with the kidney and then the ureteral stone. We're looking at nausea, vomiting. We're looking at the urine pH. We are going to do urine cultures. Blood work will include a complete blood count to evaluate the WBC, the potassium level, the BUN, and the creatinine. Then we are going to look at urine output. How much are they actually voiding? Because remember, the stone is in the ureter. So by looking at urine output, if their urine output is decreasing, that tells me that although the kidney is producing the urine, or we think the kidney is producing the urine, but it's not coming it's not coming down. Their urine output is going to be affected. And then what is the color of it? Actions. What are we going to do? We are going to administer analgesics, such as Dilaudid or morphine, as ordered. We are going to administer antiemetics, as ordered. Alpha blockers, as ordered. And we are going to maintain a fluid status, encourage PO fluids, or administer IV fluids as necessary and as ordered. And then we are going to strain that urine, because we're going to be looking for that stone. We're going to be looking for that gravel if doctor has done a lithotripsy. And now we are going to insert a Foley catheter if the client is unable to void, unable to pass their urine. So patient education. We are going to talk to them about the trial of passage. We are going to strain the urine, call the provider for fever, chills, nausea, vomiting, or pain that is uncontrolled by pain medication. Kidney stone prevention, stay hydrated, a low sodium diet, increase dietary intake of citrates, which will include lemons, lemonade, because that will help decrease the possibility of stones, and then decrease dietary intake of oxalates, which is chocolate, tea, coffee, and nuts. And then how do I know? How do I know that I've done a good job in taking care of this client? Well, the client will be adequately hydrated and will be compliant with their dietary restrictions, which means that they're going to mind their diet and they will not develop any more stones. And then a well-managed client is free from pain, no fever, has adequate amounts of clear yellow urine. Bladder cancer. Bladder cancers, ladies and gentlemen, listen up, listen up, listen up. Bladder cancer is attributed to genetic changes in target cells, and painless hematuria is the most common presenting symptoms. So when there is hematuria and there is no reason for this hematuria, your client does not have a UTI, they do not have an infection, they do not have a stone. Painless hematuria is the most common presenting symptom for bladder cancer. Diagnosis: early detection and treatment will increase survival rates. A thorough history and physical are essential first steps in reaching a diagnosis. Again, we are back to that history and physical of the client, and then that all-important family history. Risk factors will include smoking and then secondhand smoke. Blood and urine are done to look for tumor markers. Cystoscopy is used to make a definitive diagnosis, and that is when doctor actually goes up and looks into the bladder and he actually visualizes the tumor. Treatment: drug therapy for superficial low-grade bladder cancers will consist of topical therapy or an installation of solutions into the bladder. We are going right to the source. Intravesical immunotherapy, such as bacilli, calmette, guerin, is aimed at jump-starting the body's own immune defenses. So this intravesical chemotherapy will instill medications to kill actively growing cancer cells. Listen up, listen up, listen up, and listen up now. There is a safety alert on page 1413 that you will need to pay attention to. Do you understand? You need to look at the safety alert on page 1413 in your textbook. Surgical management. Surgical interventions are superficial or low-grade bladder cancers that consist of excision, fulguration, or laser ablation. So prior to treatment, a biopsy is done to determine the depth of the invasion. Intravesical chemotherapy may be given before or after the surgical excision. So complications. Complications may be related to the disease process or the treatment. Disease process complications include bleeding from the tumor in the bladder or pain caused by the impingement of other organs by the tumor. Treatment-related complications will include lasting side effects from the chemotherapy, such as peripheral neuropathy or hemorrhagic cystitis from the radiation. Actions. So what are we going to do? What are we going to do for these clients? We are going to administer medications as ordered. Sometimes you will see in the hospital setting a continuous bladder irrigation. It is called CBI, and that is where it is a dual Foley, where there's a very large saline bag, and we are instilling saline into the bladder. We're essentially irrigating the bladder, rinsing the bladder out, and then it's going to go in one part of the Foley, and then with the other part of the Foley, same Foley, the urine is going to come out and the irrigation is going to come out. And this client is going to be on accurate intake and output. How do I know? How do I know that I've done a very good job in caring for this client? Well, a well-managed bladder cancer client has an effective pain management plan in place. They are disease-free. They are symptom-controlled. They are aware because they have been educated on the treatment course and their options. Their anxiety is at an acceptable level, as self-reported or reported by family members, by their significant others. And there is an awareness of how to access support groups through peer and then professional groups, because sometimes this treatment can be ongoing. And so that's it. That's it for me. And by doing it in this manner, by presenting PowerPoint and this material in this manner and not in the classroom, ladies and gentlemen, you have escaped my weepiness. This is my last lecture with you, my last class. I will not be with you next semester when you move on. So I just wanted to say that it has been an absolute honor to be part of your journey and to get to know you and to spend this time with you, especially in such a challenging time. It's a very challenging time to be in nursing school, and I admire each and every one of you for sticking with us and for staying with us and for making it through and for being so successful. And I wish you nothing but the best as you move on.